Hello everyone, this video is about capnography, an important monitoring modality used in operation theaters, emergency care and ICUs. This slide shows a snippet of what we are going to learn in this video. Capnography refers to the study and measurement of carbon dioxide in exhaled gas. It was first introduced by Carl Friedrich Luft, a German bioengineer, in 1943. He created an infrared CO2 measuring device called URAS, or ultra-rod absorption Schreiber, but it was big, heavy and very impractical to use in clinical settings. Later, advancements in technology led to development of smaller, more portable and more accurate instruments, and measuring CO2 became possible in clinical settings. Capnography is a very important part of modern anesthesia care. According to a close claim analysis by American Society of Anesthesiologists, 93% of all avoidable anesthesia-related incidents could have been prevented with the use of capnography in conjunction with pulse oximetry. Because of this, in 1998, the ASA made it mandatory to continuously monitor end-tidal CO2 in all patients receiving general anesthesia. Today, capnography is widely used not just in operating room but in many areas of healthcare to improve patient safety. So, what exactly is capnography? It is a method that continuously displays the concentration of carbon dioxide in exhaled breath, either plotted against time, which we call time-based capnography, or against the expired tidal volume, which we call volumetric capnography. The visual representation of this data is called capnogram. We'll dissect these waveforms later in the video. For now, it is essential to recognize that the respiratory cycle consists of two main phases, inspiration and expiration. Oxygenation occurs during inspiration and refers to the delivery and utilization of oxygen by the body, while ventilation takes place during expiration and reflects the removal of carbon dioxide produced by cellular metabolism. Capnography deals with the ventilatory component of the respiratory cycle because it measures the concentration of carbon dioxide in exhaled gas. This measurement indirectly reflects the arterial partial pressure of carbon dioxide, or PaCO2, measured invasively by ABG. In other words, capnography provides a continuous non-invasive assessment of ventilation. Now, there are several methods to measure CO2 levels. The important ones of concern clinically are chemical colorimetric method and infrared spectrography. Chemical colorimetric method uses a pH-sensitive indicator housed within a device placed between the endotracheal tube and the breathing circuit. It utilizes the principle that CO2 dissolves in water to form carbonic acid, which lowers the pH. The change in pH is reflected by the color changes of the indicator with each breath. It turns yellow when exposed to carbon dioxide concentrations of 4% or greater, and purple when exposed to room air which contains little to no carbon dioxide. Their portability and design allows for quick and simple operation, making them ideal for emergency or pre-hospital settings. These devices are especially useful for immediate confirmation of endotracheal tube placement following intubation. In addition, they are very lightweight, placing a minimal stress on the end of endotracheal tube. Despite their benefits, colorimetric devices also have notable limitations. They are intended only for short-term use, typically less than 30 minutes. Moisture from exhaled gas can cause them to become saturated, rendering them non-functional. Importantly, these devices do not provide a quantitative measurement of carbon dioxide. Furthermore, in the event of esophageal intubation, they may show a false positive result from carbon dioxide if the patient have recently consumed carbonated beverages. They are also not sensitive to low concentrations of CO2, as may be seen during cardiopulmonary resuscitation or in low cardiac output states. Infrared spectrography is the most commonly used method for capnography in hospital settings. It is based on the molecular property that carbon dioxide selectively absorbs infrared light at a specific wavelength of 4.3 micrometers. In this technology, a fixed amount of infrared light is emitted from the infrared source through a gas sample containing CO2, and the remaining light that is detected on the opposite side of the infrared sensor is calculated. The difference between the transmitted and the received light is directly proportional to the concentration of carbon dioxide, and this concentration is mathematically converted into EtCO₂ displayed on the monitor. The devices which use this technology are called capnometers. Unlike the colorimetric method, infrared capnography provides continuous breath-by-breath waveform analysis and offers the benefit of continuous monitoring, and it is quantitative too. This helps assess the patient's airway status and the effectiveness of ventilation. These monitors are sensitive enough to detect very small amount of CO2 in exhaled gas, even when the concentration is less than 1%. So they are capable of accurately measuring CO2 during CPR. One limitation of this method is that the sensor used can be bulky, potentially adding strain at the end of endotracheal tube. Additionally, sample tubing or electrical lines connected to the ET tube can increase the risk of unplanned extubation, posing a sudden airway emergency. Most capnography units require some level of maintenance and consumable supplies such as batteries and airway adapters. Lastly, the equipment is also expensive compared to the colorimetric devices. There are two types of capnometers, mainstream and sidestream. In mainstream capnometry, the infrared sensor is placed directly in the path of respiratory gas and is connected to the monitor by an electrical cable. In sidestream capnometry, a sample of exhaled gas is continuously aspirated through a lightweight airway adapter, and a sampling tube relays it to the monitor where the actual sensor is located. Mainstream capnography has several advantages. First up, since it does not require a sampling tube, there is no risk of tube obstruction. It captures the infrared absorption of CO2 in real time under the same ambient condition as patient's airway. This avoids the influence of external environmental changes such as pressure drop or added moisture. And because it provides direct measurement of exhaled gas, both the waveform and the numerical readouts are available in real time with no sampling delay. There are also some disadvantages associated with mainstream capnography. The airway adapter and the sensor adds weight to the end of the endotracheal tube, which often requires additional support. In older models, there have been reports of minor facial burns. The sensor window can become obstructed by secretions affecting accuracy. Additionally, the positioning of sensor and airway adapter can be challenging in certain patient positions, such as the prone position. Sidestream capnography offers several practical benefits. The sampling capillary tube and airway adapter are easy to connect, making setup straightforward. Sidestream capnography can be used with patients in almost any position, including the prone position. It is also suitable for use in awake patients through a specially designed nasal cannula or face mask. Despite its advantages, sidestream capnography has some limitations. The sampling capillary tube can be easily obstructed by water or secretions, which may interfere with the gas flow. Changes in water vapor pressure within the sampling line can also affect the accuracy of CO2 measurement. In pediatric patients, the waveforms are often unclear or distorted due to small tidal volumes. Furthermore, because the gas sample must travel through the tubing to reach the sensor in the monitor, there is a slight delay in both the waveform display and the numerical readout. As we have seen earlier, the waveform of capnograph is either plotted against time or against the expired tidal volume. Let's look at the volume-based capnography waveform. Volume-based capnography plots the CO2 concentration against the volume of exhaled gas during a single breath. The exhaled gas is plotted on the x-axis and the CO2 concentration on the y-axis. As the patient exhales, the graph progresses through three distinct phases, reflecting the composition of exhaled gases at different points in the respiratory cycle. The three phases are named phase 1, 2, and 3. At the beginning of the exhalation, the gas leaving the airway comes from the anatomic dead space, like trachea and bronchi, where no gas exchange occurs. This gas contains no CO2, so the CO2 concentration remains at 0. On the volumetric capnogram, this phase appears as a horizontal line near 0 on the y-axis at the start of exhaled volume. As the exhalation continues, the gas from the alveoli begins to mix with the dead space gas. Since the alveolar gas contains CO2, the CO2 concentration begins to rise. On volumetric capnogram, this phase shows a steep upward slope indicating a rapid increase in CO2 concentration as more alveolar gas reaches the sensor. By phase 3, most of the exhaled gas is coming from the alveoli. The CO2 concentration stabilizes, producing a relatively flat or slightly rising plateau. This portion of the curve represents uniform alveolar ventilation and is used to determine the end-tidal CO2. It allows for the calculation of important respiratory parameters such as dead space ventilation, but requires specific, often more expensive monitoring equipment that measured exhaled volume and CO2 concentration simultaneously. So it is commonly used in research setting and in advanced respiratory monitoring. For common clinical tasks such as confirming EtCO₂ placement, monitoring trends in ventilation, or detecting apnea, time-based capnography provides enough information. So I won't be discussing volume-based capnography any further. Now let's look at time-based capnography. Time-based capnography is the most commonly used method for monitoring CO2 in clinical practice. It displays a continuous waveform that shows how the concentration of CO2 changes over time during the respiratory cycle, including both inspiration and expiration. The capnogram is divided into 4 distinct phases, each representing a specific part of respiratory cycle. Phase 1 corresponds to early exhalation, during which gas from the anatomic dead space is expelled. Since no gas exchange occurs in this region, the exhaled gas contains no CO2 and the waveform remains at baseline. Phase 2 is the ascending phase. Here, CO2-rich alveolar gas begins to mix with dead space gas, causing a rapid increase in CO2 concentration. The steepness of the slope reflects the uniformity of alveolar emptying. Phase 3 represents the alveolar plateau. This portion of waveform reflects gases coming predominantly from the alveoli with relatively stable or slightly rising CO2 level. The end of this phase corresponds to the end-tidal CO2 value, which is the highest concentration of carbon dioxide during that particular respiratory cycle. Following that, inspiration begins, which is the phase 0. During this phase, fresh gas enters the airway and the CO2 level drops sharply to 0. The angle between phase 2 and phase 3 of capnogram is called alpha angle. An increase in alpha angle suggests a prolonged phase 2, which is typically seen in conditions such as bronchospasm or partial airway obstruction, where expiratory flow is impaired. The beta angle is formed between phase 2 and phase 0 of the capnogram. An increase in beta angle indicates partial rebreathing of exhaled CO2, which may occur in situations such as foreign body, partial airway obstruction, or laryngospasm. The presence of phase 4 on capnogram suggests uneven emptying of lungs, typically due to asymmetrical airway resistance. This may result from a unilateral bronchospasm or partial obstruction in either the left or right bronchial tree. The normal end-tidal CO2 value ranges from 30 to 40 mmHg. In clinical practice, however, EtCO₂ is typically 3 to 5 mmHg lower than the arterial CO2 or PaCO₂ measured via arterial blood gas. The difference between these two values is known as arterial end-tidal CO2 gradient. This gradient is directly proportional to dead space ventilation, which refers to the portion of ventilation that does not participate in gas exchange. There are several conditions that causes an increase in the arterial to end-tidal CO2 difference, indicating a rise in physiological dead space. Dead space gas comes from parts of lungs where ventilation occurs without effective perfusion, meaning little or no CO2 is exchanged. As a result, the gas exhaled from these regions contains very low CO2, which dilutes the overall concentration of CO2 in the exhaled breath. These conditions include pulmonary embolism, where blood flow to the parts of the lung is blocked, emphysema, which impairs alveolar gas exchange, and low cardiac output states such as hypovolemia, which reduces pulmonary perfusion. But to measure arterial to end-tidal CO2 difference, we need to perform EBG to get the value of arterial CO2 or PaCO₂. So we rely on end-tidal CO2 to gain a wide range of information. There are several factors that influence EtCO₂ level. These are ventilation, circulation or cardiac output, and metabolism. Ventilation refers to the movement of air in and out of the lungs, and it is primarily determined by tidal volume and respiratory rate. If ventilation is decreased due to low tidal volume or reduced respiratory rate or both, less CO2 is exhaled, leading to a rise in end-tidal CO2. Conversely, if ventilation increases through a higher respiratory rate or larger tidal volume, more CO2 is eliminated and EtCO₂ levels fall. Circulation, or more specifically cardiac output, affects how efficiently CO2 is transported from tissues to the lungs. If cardiac output is reduced, as in shock, cardiac arrest or severe heart failure, less CO2 is delivered to the alveoli for exhalation, resulting in a lower EtCO₂ reading. Conversely, a high cardiac output, as seen in states like fever, sepsis or exercise, increases the transport of CO2 to lungs, which may raise EtCO₂ levels if ventilation remains unchanged. Metabolism refers to production of CO2 at cellular level. In conditions of increased metabolic activities such as fever, sepsis or shivering, more CO2 is generated, which can raise EtCO₂ level if ventilation and circulation are adequate. In contrast, conditions that suppresses metabolisms like hypothermia may lead to lower CO2 production and lower EtCO₂ values. Apart from these factors, there are factors that increases dead space like pulmonary embolism and emphysema causing ventilation without perfusion. This widens the arterial to end-tidal CO2 gradient and lowers EtCO₂ despite adequate ventilation. Another type of dead space called apparatus dead space can lead to rebreathing of CO2, resulting in falsely elevated EtCO₂ levels and increased work of breathing. This is especially significant in infants and small children due to their smaller tidal volumes. Apparatus dead space includes the volume within face masks, connectors, or unnecessarily long endotracheal tube where exhaled gas may be rebreathed without participating in gas exchange. Additionally, in anesthesia machines, exhaustion of CO2 absorber can also raise EtCO₂ by allowing CO2 to accumulate in the circuit. Now let's look at some clinical indications of capnography. Capnography has several important clinical indications. It is used during endotracheal intubation to confirm proper placement of endotracheal tube. During procedural sedation, it provides continuous monitoring of patient's respiratory pattern. In mechanical ventilation, capnography is valuable for assessing the effect of changes in ventilatory settings. Under general anesthesia, it helps monitor both pulmonary function and cardiac output status. Additionally, during cardiopulmonary resuscitation, capnography is used to evaluate the effectiveness of chest compression and can predict the likelihood of successful resuscitation. Capnography plays a critical role during endotracheal intubation by confirming the correct placement of endotracheal tube in the trachea rather than esophagus. The consistent presence of CO2 over 4 to 5 breaths indicates that the tube is correctly placed in the trachea. In contrast, placement in esophagus results in either no CO2 detection or only a transient signal if carbonated beverages or solid air is present, with waveform quickly returning to the baseline. It also helps detect tube dislodgement or obstruction promptly. Capnography serves as an indicator of ventilation and provides a real-time assessment of a patient's respiratory status because the waveform directly correlates with the act of breathing. Unlike pulse oximetry, which reflects oxygenation and can delay detection of hypoventilation or apnea by several minutes, capnography identifies ventilatory compromise instantly even before oxygen desaturation occurs. This makes it particularly valuable during procedural sedation where respiratory depression is a known risk. For optimal patient safety, capnography should always be used alongside pulse oximetry during procedural sedation. When a critically ill patient is put on mechanical ventilation, both oxygenation and ventilation must be carefully monitored. Oxygenation is assessed by measuring oxygen saturation using pulse oximetry or directly by PaO2 from arterial blood gas. Ventilation, on the other hand, refers to the removal of CO2 from the body and is assessed by measuring arterial carbon dioxide or PaCO2. While ABGs provide an accurate but intermittent and invasive measurement of PaCO2, capnography allows for continuous non-invasive monitoring of end-tidal CO2, which is a close estimate of PaCO2 under stable conditions. So capnography improves the management of mechanically ventilated patients and may reduce the need for frequent ABG sampling. Capnography is a very important monitoring modality in general anesthesia. After anesthesia induction, capnography is first used to verify ET tube placement after endotracheal intubation. During surgery, capnography is used to monitor airway status, ventilatory status, and pulmonary perfusion status. The waveform is closely watched for any changes in shape which will alert anesthetists of anything from bronchospasm to dislodgement of ET tube. During surgery, a sudden decrease in EtCO₂ can alert anesthetists of changes to ventilation status. A sudden decrease in EtCO₂ indicates a sudden increase in alveolar dead space, leading to suspicion of acute pulmonary thromboembolism or air embolism. A sudden decrease in EtCO₂ can also mean an acute decrease in pulmonary perfusion. Capnography is a valuable tool during CPR by providing real-time information about the effectiveness of chest compression and overall perfusion. Since CO2 is transported to the lungs via circulation, the presence of end-tidal CO2 reflects cardiac output. A sudden rise in EtCO2 is often the first sign of return of spontaneous circulation or ROS. Conversely, persistently low EtCO2 levels, typically below 10 mmHg, may indicate inadequate or poor compression quality. A falling EtCO2 can therefore be used as an early objective sign that rescuers should be rotated to maintain effective perfusion during CPR. Capnography can also help predict outcome during CPR. Studies have shown that an initial EtCO2 of less than 8 mmHg is associated with survival rate of less than 1%, whereas EtCO2 greater than 18 mmHg is associated with a 70% greater chance of survival. Finally, we have reached the most interesting part of this video, the interpretation of capnography waveforms. Let's begin by looking at the normal capnograph. We have already discussed the anatomy of normal capnogram, which consists of 4 phases labeled phase 0 to phase 3. Each phase corresponds to the changing concentration of CO2 at different points in the respiratory cycle. The waveform is also described by labeling the waveform with alphabet A, B, C, D, and E, as it provides a simple and intuitive way to discuss capnography without needing to recall the physiological phase names. The segments A, B, C, D, and E corresponds to different phases of respiratory cycle. The segment A to B represents phase 1, where exhaled gas from the anatomic dead space contains no CO2, so the waveform remains at baseline. From B to C, phase 2 begins and there is a rapid rise in CO2 concentration as alveolar gas mixes with the dead space gas. The segment C to D represent phase 3, also known as alveolar plateau, where mostly alveolar gas is exhaled, causing a gradual rise in waveform. Point D marks the end of exhalation and reflects the end-tidal CO2, which is the highest point on the capnogram. Finally, the segment from D to E represent phase 0, where inspiration begins and CO2 level rapidly drop to 0 as fresh gas enters the airway. We should also note of the normal EtCO2 value, which is between 30 to 40 mmHg. An increasing EtCO2 level on the capnograph waveform is seen as a gradual upward shift in the alveolar plateau or phase 3 and a rise in end-tidal CO2. This pattern may indicate hypoventilation due to a reduced respiratory rate or tidal volume, leading to CO2 retention. It can also result from increased metabolic activity such as fever, seizure, and sepsis. A rising EtCO2 may be a sign of improving perfusion, particularly during CPR when return of spontaneous circulation occurs. Additionally, rebreathing of CO2 due to an exhausted CO2 absorber, increased apparatus dead space, and exhalation obstruction can also cause a progressive increase in EtCO2 levels. A decreasing EtCO2 level on capnograph waveform is seen as a downward trend in the height of alveolar plateau and a lower end-tidal point. This may indicate hyperventilation, where an increased respiratory rate or tidal volume causes excessive elimination of CO2. It can also result from reduced metabolic activities such as hypothermia or sedation. More importantly, a falling EtCO2 may reflect impaired circulation such as in shock, hypovolemia, or cardiac arrest, where less CO2 is delivered to the lungs for exhalation. Pulmonary embolism and increased dead space ventilation can also cause a drop in EtCO2 due to poor perfusion of ventilated alveoli. Additionally, Technical issues like disconnected circuit or leaks can falsely lower the EtCO₂ reading. Rebreathing on the capnograph is indicated by a waveform that does not return to the baseline during the inspiratory phase, showing the presence of CO2 in the inspired gas. This suggests that the patient is inhaling previously exhaled CO2. This might also lead to an increase in EtCO₂ level. Common causes include exhaustion of CO2 absorber in anesthesia machine, faulty unidirectional valves, increased apparatus dead space, or inadequate fresh gas flow in non-rebreathing systems. Obstruction in breathing circuit is reflected on the capnograph waveform as a slanted or prolonged expiratory upstroke or phase 2 and a slow rising alveolar plateau. The waveform appears delayed and less steep, indicating difficulty in exhalation. In severe cases, the plateau may never be reached and the waveform may appear rounded or shark fin shaped. This pattern suggests a partial airway obstruction or increased airway resistance, which may result from conditions such as bronchospasm, kinked or blocked endotracheal tubes, or mucus plugging. A curare cleft is a small notch or dip seen in the alveolar plateau of the capnograph waveform. It represents a spontaneous respiratory effort made by the patient during mechanical ventilation, usually due to incomplete neuromuscular blockade. The presence of a curare cleft suggests that the patient is beginning to regain diaphragmatic activity and attempting to breathe between the ventilator-delivered breaths. This indicates that the muscle relaxant is wearing off and an additional dose may be needed if continued paralysis is required. Once a muscle relaxant is re-administered, the cleft may disappear and the plateau becomes smooth again. As discussed earlier, capnography plays a critical role during endotracheal intubation by confirming the correct placement of endotracheal tube in the trachea rather than the esophagus. The consistent presence of CO2 over 4 to 5 breaths indicates that the tube is correctly placed in the trachea. In contrast, placement in the esophagus either results in no CO2 detection or only a transient signal if carbonated beverages or solid air is present. However, the waveform quickly returns to baseline. It also helps detect tube dislodgement or obstruction promptly. An inadequately sealed endotracheal tube shows an irregular alveolar plateau on the capnograph waveform, often failing to reach a flat or stable plateau. This pattern occurs when exhaled CO2 escapes around the tube or is diluted by entrant room air, leading to falsely low EtCO₂ values. The waveform may also display variable shapes between breaths due to inconsistent leakage. Cardiogenic oscillations on the capnogram appears as a small, regular wave-like undulations superimposed on the alveolar plateau and sometimes extending to the descending limb of phase 0. These are caused by the mechanical movement of heart against the lung, which creates minor gas fluctuations in the airway. So the waveform is synchronized to the heartbeat. They are most commonly seen in pediatric patients with low tidal volumes, high cardiac output, and thin chest walls. Cardiogenic oscillations are benign finding and do not require intervention.